Welcome to The Explainer. Today, we're jumping into something that, let's be honest, can be pretty intimidating, the pediatric musculoskeletal exam. But don't worry, we're going to show you how to take all that stress and turn it into a super clear, systematic approach.
All right, let's just get right into it. For so many of us, the Pediatric MSK exam just feels, well, chaotic, right? You've got dozens of different maneuvers, a ton of joints to check, and usually a kid who, isn't exactly thrilled to be there. It's just a lot to juggle, especially when you're under pressure.
But what if I told you there's a secret, a really clear, powerful, streamlined approach? I'm talking about a system so simple you could literally map it out on one single piece of paper, turning all that chaos into pure confidence. And that's exactly what we're going to build together in this explainer.
Okay, so here's the first big takeaway. It doesn't matter what the child's main complaint is. Every single great MSK exam starts with the exact same foundation, the general examination. Think of this as setting the stage for everything else that's about to follow.
And the best part? The structure is super easy to remember with a simple little mnemonic, SSGB. So that's S for screening questions, S for symmetry and standing, G for gait, and B for the back exam. Now, let's actually break down what each of these really means in practice.
Now, these are the little things, the pro tips that really separate a good exam from a truly great one. First up, instead of asking a bunch of different questions, be efficient. Use one killer screening question that covers everything, like, do you have any pain going up or down stairs, brushing your hair, or trying to tie your shoes? Boom. You've just covered lower limbs, upper limbs, and the back all in one go. And hey, full exposure is non-negotiable. That means the socks have to come off. A couple more things. You move around the patient. Don't make them turn for you. And always, always, always compare one side to the other. You're constantly looking for differences.
So, once you've nailed that general exam, you get to this critical fork in the road. And honestly, this is where the real power of this system kicks in. Your entire game plan from this point forward hinges on the answer to one single question. And here it is. You have to ask yourself this, plain and simple. Does this patient have clinical evidence of arthritis? That's it. The answer, a simple yes or no, is going to send you down one of two very different paths. This is the absolute central decision point of the whole exam. But, to answer that question with any real confidence, you need a rock-solid definition of what you're even looking for. So what is arthritis, clinically? Well, it's pretty straightforward. It's either the presence of joint swelling or an effusion, that buildup of fluid. If you see that, you're done. That's arthritis. If you don't see that, then you're looking for at least two of the following: redness, hotness, or tenderness in that joint. Got it? All right, so depending on your answer to that big arthritis question, you're headed down one of two very distinct pathways. You're either going to do a broad general screening exam, or you're going to do a deep dive focused examination. And here's the whole decision tree on one slide. It's actually that simple. If there's no arthritis, your job is to use the PGALS screening exam. That's a quick, efficient screen of everything: gait, arms, legs, and spine. But if there is arthritis present, you completely switch gears and go for the detailed look, feel, move examination on that specific joint. So let's talk about that no arthritis pathway. Your goal here is a quick but really thorough screen. You're not hunting for one specific problem. Instead, you're casting a wide net just to make sure you don't miss anything subtle. The PGALS protocol is perfect for this. It guides you through this whole standardized set of movements for the arms, legs, and spine and lets you screen the entire system super efficiently. But when arthritis is present, everything changes. Your focus narrows right down. You basically become a detective investigating a very specific crime scene. You follow that classic sequence. First, you look. Look closely at the joint, the skin, everything. Then, you feel for temperature, for tenderness, for that effusion. And finally, you ask the patient to move the joint through its active range of motion. And please don't forget this last part. Always examine the joint directly above and below the one in question. This is so important because pain can be referred. A classic example is a hip problem showing up as knee pain. This step makes sure you don't miss the real culprit. Okay, so you've found arthritis. Now what? Well, this is where you really level up your skills. The biggest, most important clues are often found outside the joint itself. You have to start thinking systemically. You have to become a real clinical detective. So what does that look like? It means you're doing a full-body scan, head to toe, for these associated signs. You're looking in the eyes for any redness. That could be uveitis. You're checking the mouth for ulcers. That points you toward things like SLE or IBD. You're looking carefully at the skin, the nails. Any changes there could scream psoriasis. Is there any hair loss or alopecia? And of course, don't forget to feel for any enlarged lymph nodes. Each one of these clues is a piece of the puzzle that can point you straight to the right diagnosis.
All right, you've done all the physical maneuvers, the hands-on part of the exam is over. But listen, your job is not done. In fact, what you do next is what really defines you as a competent, caring clinician. Look, in the heat of the moment, it is so tempting to just try and jump to a diagnosis, to name the condition. But your first step, your immediate goal isn't that. It's about making sure this child is safe, that they're comfortable, and that they're getting on the right management path. Patient care, teamwork, that stuff always comes first.
So what does that look like in practice? It's a safe, structured, professional approach. Step 1, deal with the child's pain. Get them some analgesia. Step 2, take a full history to get all the context you need. Step 3, call your senior. Escalate appropriately. And step 4, start assembling the team. We're talking physio, occupational therapy, the whole crew.
So there you have it. We've taken what feels like a crowded, totally chaotic examination and turned into a clear, logical map. You start with that SSGB framework, you hit that critical fork in the road and pivot based on arthritis, and you finish up by thinking like a true clinician. Now you have the system, so the only question left is, what's your first move going to be when the next MSK patient walks through that door?